Okay. So it's definitely a pleasure to join you guys today and to talk to you about my story in arriving at my career as a surgical breast oncologist. And you can see from the title slide here where I've kind of summarized the different positions that I hold. I do wear a lot of hats, and that does keep me pretty busy, but it's the spectrum of my different responsibilities that really makes my job so wonderful to me, and I truly enjoy and cherish every single day that I come to work. I love telling young people that I meet that one of the best things about my work is that I literally wake up every day feeling that I'm going to the best job on the planet. And I wish to all of you that you find careers that are comparably gratifying. It's just wonderful. So I am a professor of surgery and chief of the breast section here at Weill Cornell Medicine and for the New York Presbyterian Hospital Network, where I coordinate our multidisciplinary breast cancer program. Another position that I am really proud of, and I'll talk to you a little bit about it at the end of this presentation, is that I serve as faculty champion for our Department of Surgery Anti-Racism Committee, which gives me a lot of really fun opportunities to interact with young people as we develop our pipeline programs to try to improve and strengthen the diversity of our surgical workforce. And my research platform has pretty much always over the past 20 years focused on addressing breast cancer disparities. And that work has evolved into a robust global medicine and international research program, which is housed under the structure of a center that I founded, the International Center for the Study of Breast Cancer Subtypes. And I'll also, during this presentation, talk to you about some of that research and about some of the work that I do in Africa over the past 20 years. In terms of other positions associated with different organizations, I continue to be an adjunct professor with the MD Anderson Cancer Center, which is where I received my surgical oncology training and where I had my first faculty position as a surgical oncologist. And I have a number of cherished roles with the Susan G. Komen Breast Cancer Foundation. I'm also on the board of directors for the American Association for Cancer Research, the editorial board for JAMA Surgery, and yet another one of my proudest roles is to serve as Chief National Medical Advisor for the Sisters Network Incorporated, which is a national African-American breast cancer advocacy and survivors organization. So covers a spectrum of responsibilities, but it's so much fun. I absolutely love my work. And for some reason, okay, now we're advancing. Okay, so I want to start by emphasizing a huge problem that we have in medicine, which is the lack of diversity in our healthcare workforce. And as you guys, I'm sure, are all aware, African Americans comprise about 13% of the United States population, but only about 5% of American physicians. And unfortunately, this is a bit of a self-perpetuating problem because many physicians today become interested in medicine as a career because they have family legacies of medicine where they have parents, aunts, uncles, grandparents who were all physicians. And so they kind of come by it naturally. But in the African-American community, for a variety of historical issues, which we will also touch upon in this presentation, there just is a huge dearth of African-Americans in the generational issues. And so with the current generations of African-Americans not having that type of exposure to medicine and the sciences in their families, they're less likely to be interested in careers in healthcare themselves. And so many of us that are African-American in the physician workforce developed our interest in medicine through somewhat atypical routes. And I'm certainly no exception. So this is my family dating back to my parents' parents. And in this top left-hand corner photograph, this is the family of my father. My paternal grandfather and paternal grandmother both immigrated to New York from a very tiny island in the West Indies called Dominica. And they immigrated to New York, landing in Harlem ultimately when they were 13 years old, but they actually didn't know each other when they were on the island of Dominica. They met in Harlem, fell in love, and raised this good-sized family of 5 kids. And my paternal grandfather was quite fortunate. Back then, there weren't many professional opportunities for African-American families in Harlem. So it was a struggle to raise their family of 5 kids, but they did so because my paternal grandfather was able to land a job in the post office. And that was a really plum position back in that time of the early 1900s for a Black family. But it was still quite a struggle for them to raise these 5 kids. They were very devout Christians, and they managed to do so and kept almost the entire family together and on the straight and narrow. And they all finished school and did very well in life, except for this little guy who looks like an absolute angel, the youngest kid in the family. He looked so angelic in this picture, but he was anything but. And this is my father. And my dad, with the 4 older kids, he kind of was the kid that fell off the map and didn't remain under my grandmother's thumb quite so much. So he actually got into quite a bit of trouble when he was a youngster. He ended up dropping out of school before ever reaching high school, so never set foot into high school at all, had his issues. But then he met this fabulous, gorgeous woman, my mother, who really helped him get back on the straight and narrow path. And my mom saw something special in my dad. They met while he was actually in the military, where he was definitely able to get himself straight in the head and develop some ambition. And my mother really encouraged him to pursue higher education. So he ended up getting through college on the GI Bill, and my mom supported him to actually get through law school. And as they became somewhat more successful as a Black couple, going back to, I guess this must have been like the 1950s now. They moved us up in the world. So we moved from Harlem to the projects in Queens. And this photograph down at the bottom is taken from one of their first apartments in Queens. This is my older sister. That's me, my younger brother, our younger brother. And I show this photograph really just because I love this slide of the couch in their apartment in the projects in Queens. Back then, I don't know how any of us survived. The families always kept all the furniture swathed in plastic to protect the furniture from the kids. How we ended up not smothering, I have no idea. But this photograph, it just cracks me up because it also represents how my parents moved up as they became more successful, and as my mom continued to get my dad to be somewhat more ambitious in his life. So there were no physicians in my family, and so I had no role models to speak of in terms of developing an interest in medicine. But after my mom was finished working in my dad's law office during the day, we would meet at home after school, and one of our bonding activities every afternoon was to watch the soap opera General Hospital. And you guys probably don't even know what soap operas are anymore. You watch all your stuff on the iPhones, but General Hospital was one of the many soap operas out there that cataloged life in the hospital and law, of course, a number of different walks of life. And for me, that was the only exposure that I had to being a physician. And I wanted to be just like Dr. Leslie Weber here. Now, medicine is nothing like the way it was depicted in this soap opera. Dr. Leslie Weber was a neurologist in the morning, then she was a psychiatrist in the middle of the day. She was an emergency room trauma physician in the evening. And then I think she was even a psychiatrist in some of the episodes. But it just seemed like such a cool life. She always had great clothes, and she always had good looking physician boyfriends. So as a kid, that just seemed like the job to have. So I became enamored of the prospect of pursuing a career in medicine, and it's nothing like Dr. Leslie Weber's job, but it did work out well for me. And I have never had one regret looking back. But this is the way my educational and professional journey rolled out. As I mentioned, as my father's law career became progressively more successful, and I have to give huge amount of credit to my mom here in making that happen. The two of them, just amazing, amazing individuals. They were very involved with the African-American community and civil rights movement, and that rolled into creating some of the success of my dad's law practice. Ultimately, they moved us out to Long Island, and I graduated from Half Hollow Hills High School out in Dix Hills. Then I went on to complete my undergraduate training at Harvard, and I came back to New York for medical school, and I stayed in the Brooklyn system for many, many years, because in medical school, I really fell in love with general surgery. I loved pretty much all of my rotations in medical school, but once I walked into the operating room, I knew there was nothing else for me except being a surgeon. So I ended up staying on staff as a practicing general surgeon and an assistant professor of surgery on the CUNY downstate faculty for 7 years. And my practice in general surgery was based in Brooklyn. And that's where I developed my interest in my career as it sits today. Brooklyn, as I'm sure you guys are aware, is a beautifully, robustly diverse community. And one of the things that really struck me back in the 1990s in taking care of large numbers of patients, not only with benign surgical problems like trauma, critical care problems, cholecystitis, colitis, a lot of different benign problems, but I also took care of a lot of cancer problems, and a lot of women patients gravitated to my office practice because they wanted a woman to take care of their breast problems. And so I ended up developing a pretty large breast cancer practice as well. And I couldn't help but be struck and also horrified by the patterns that I was seeing in my own office-based practice, where my Black breast cancer patients seem to be diagnosed at much younger ages than my white breast cancer patients, and they seem to have much more challenging breast cancers to treat successfully. And so I wanted to become involved with research. And that's what motivated me to actually go back to training. And after 7 years of being my own surgeon as a general surgeon in practice, I ended up pursuing fellowship training in surgical oncology. But I was very fortunate to match in surgical oncology fellowship training at the MD Anderson Cancer Center, which to this day is one of our premier cancer centers in the world. And I was even more fortunate that I was recruited to stay on the faculty at MD Anderson. And from that point on, my career has been dedicated to surgical breast oncology. But I did develop a strong research platform in the context of that fellowship training and then being on staff at MD Anderson as well. So for surgeons that are interested in research and academia, it's not uncommon for us to move around based upon sometimes personal reasons, but sometimes based upon academic professional opportunities that come around. For personal reasons, family reasons, I ended up having to relocate to Michigan after being in Houston, Texas for several years. And my first job in Michigan was to serve as associate director of the breast center for the Kamanos Cancer Institute located in Detroit. And shortly thereafter, I was recruited to serve as director of the breast care center for the University of Michigan. And a big chunk of my professional and academic career was based at the University of Michigan in Ann Arbor. And my research platform really accelerated at that point at the University of Michigan, because the University of Michigan had a long-standing exchange program with some hospitals in Ghana for their maternal and fetal health program. So as I became more involved with breast cancer research involving African ancestry, I was able to evolve that disparities research program into an international research program evaluating breast cancer in African women on the continent of Africa. Well, and I was at University of Michigan for close to 15 years, 13 years, quite a long time. But then a wonderful opportunity came around for me to serve as director of the multidisciplinary breast program for the multiple hospital system in the Henry Ford Health System, also located in Michigan. But I was only at Henry Ford for a couple of years when an incredible opportunity came my way that I absolutely couldn't turn down, where my career came full circle and I was able to return to my hometown of New York. And in August of 2018, I assumed the position of chief for the breast program at Weill Cornell Medicine and for the New York Presbyterian Hospital Network, where I have the distinct pleasure and honor of overseeing the multidisciplinary program involving our campuses here on the Upper East Side of Manhattan, but also in Brooklyn and in Queens. So it's a really, really fun job for me. So I was asked to make sure that I talk to you guys about my daily activities, and it involves quite a spectrum of different activities. My full-time cadre of responsibilities involves caring for breast cancer patients. And so I am in clinic nearly every day. I'm in surgery almost every day as well. And through our conference system, I coordinate our multidisciplinary care across our network. And I do want to stress multidisciplinary care in our breast cancer patients, because most breast cancer patients will not only require surgery, but they will require management from colleagues in other disciplines, such as radiation, medical oncology, sometimes precision medicine oncology. They require a lot of different types of care, but because we've made so many advances in the multidisciplinary care of breast cancer, one of the great aspects of my job is that I can honestly tell nearly all of the patients that I meet that the odds are in their favor that they will have a good outcome as long as they complete their treatment. Most women with breast cancer will be long-term survivors. Then I do have a number of administrative and academic responsibilities with regard to teaching both our medical students and our general surgery residents. And my research responsibilities have also continued in terms of the international work that I conduct and the studies that we do through our program, which is called the International Center for the Study of Breast Cancer Subtypes. And community outreach continues to be part of my heart and soul. And I love being able to interact with different community-based organizations in expanding and strengthening messages regarding breast health awareness and in our attempt to address disparities and to achieve health equity. So this is just a synopsis of our multidisciplinary tumor board meetings. And these multidisciplinary tumor board meetings are the bedrock foundation of our breast program, because these tumor board meetings are the venue where our entire team comes together to review every single breast cancer patient that is treated in our system. So it brings together not only my surgical colleagues, but my colleagues in medical oncology, radiation oncology, the radiologists, the breast imagers, the breast pathologists, plastic surgeons, and our research team, in turn, including our nurse practitioners. We all come together to discuss every patient, to make sure that all of the I's are dotted and the T's are crossed in the management plan that we implement for our patients. And we document our discussions so that everybody stays on the same page as the patient's treatment rolls out across the continuum of their care. And this is simply an example of some of the cancers that we diagnose. Many of them are mammography screen detected cancers. Over here, this is a very tiny cancer that's been detected on a woman's mammogram. The one at the bottom of this slide is a somewhat bulkier cancer. Unfortunately, we do continue to see cancers that are 3-4 times as large as the one shown here. But on this particular slide, I'm showing you patients that have relatively early stage breast cancer. And for those women with relatively early stage breast cancer, this is an example of some of the surgical procedures that I commonly perform throughout the week. Partial mastectomy, which will sometimes involve the assistance from the radiologist in terms of localizing these tumors. At our facility, that localization will either involve insertion of a radioactive seed and a gamma detection to identify the location of the tumor. Sometimes we perform mastectomy surgery. Often the total mastectomies are performed in conjunction with our plastic surgery colleagues for breast reconstruction, which is done right at the same time as the mastectomy. We also do staging procedures for the lymph nodes of the axilla in the form of either a sentinel lymph node biopsy, which is a minimally invasive lymph node procedure, or sometimes we will have to do a more extensive lymph node operation called an axillary lymph node dissection. So now I do want to take a few minutes to talk to you about our research program. And the basis of this program is something that we call Oncologic Anthropology, where we try to study breast cancer disparities related to African ancestry through the lens of understanding African population migration patterns over the past several hundred years. Now, when we talk about disparities, we do have to go back to the World Health Organization's definition for social determinants of health, which are the conditions in which people are born, grow, live, work, and age, as well as a broader set of forces that shape daily life conditions. And nobody would argue that poverty is an extremely powerful social determinant of adverse health. And as shown by this slide, poverty rates are substantially higher in our communities of color, including Blacks, African Americans, and the Hispanic Latinx community. Poverty, of course, goes hand in hand with being uninsured or being unemployed, and both of these socioeconomic disadvantages are notably higher in African Americans and the Hispanic Latinx community. So it's not surprising that many threats to health and longevity are also disproportionately severe in both Blacks and the Hispanic Latinx community. Examples of some of those comorbidities being obesity, poorly controlled hypertension, and a series of other health threats, most recently seen in COVID mortality as well. But the very unique history of Africans in the United States have left us with some very unique features impacting the health of African Americans today. Slavery was, of course, abolished more than 150 years ago, but we continue to live with the legacy of slavery today in the form of residential systemic racism and residential racial segregation. And this is a consequence of practices that occurred after slavery was abolished. For example, redlining, where banks were legally allowed to literally zone African-American neighborhoods out of opportunities for mortgaging and financing so that they couldn't own their own homes or their own businesses. And this left many African-American families essentially trapped over the past several generations in neighborhoods that feature food deserts, nutritional insecurity. These are neighborhoods that are typically denser in terms of their population, which definitely contributed to the COVID severity. And these neighborhoods have poorer public school systems, leaving the current generations of these African-American families with fewer employment prospects, fewer higher education prospects. And all of these factors will impact on ability to access best health care. So you can see the products of these types of problems when we look at breast cancer disparities and the impact of breast cancer on the African-American community. Because of these socioeconomic disadvantages, we see a more advanced stage distribution for breast cancer in Black women, with Black women being diagnosed with the bulkier, larger cancers. And this plays out in the higher mortality rates, death rates that we see from breast cancer in Black women compared to white women. And this close correlation between socioeconomics and African racial identity leads many to raise the question of whether race has any relevant genetic biologic value, or is race pure and simple a sociopolitical construct? The answer to that question, of course, is that racial identity is complex, and those two aspects of its definition are not mutually exclusive. Racial identity is indeed a sociopolitical construct. How we self-identify, as well as how society labels us, will definitely influence how we live, where we live, and how we access healthcare. But racial identity is also associated with a whole host of ancestral genetic factors that can also contribute to cancer burden. And we've actually known for many decades that issues, factors aside from socioeconomics contribute to breast cancer disparities specifically. And an example of this evidence comes from a study that I had the opportunity to publish with some colleagues from the Harvard School of Public Health nearly 20 years ago, where we simply pulled together all of the studies in the published literature looking at breast cancer survival in Black women compared to white women after accounting for some measure of socioeconomic status. And even after you account for socioeconomics, the Black breast cancer patients continue to have a nearly 30% higher mortality hazard. So definitely there are issues at play aside from socioeconomics when we look at the specific problem of breast cancer disparities. Furthermore, as shown on this slide, there's a whole litany of characteristics describing the breast cancer burden of Black women compared to white women that we can't easily ascribe to socioeconomics. For example, Black women tend to be younger when they're diagnosed. This is exactly what I saw in my own practice back in Brooklyn several years ago. But on a national basis, we see that Black women are significantly more likely to be diagnosed with breast cancer in premenopausal ages compared to white women with breast cancer. Black women have a higher risk for being diagnosed with biologically more aggressive breast cancer subtypes, such as one that we call triple negative breast cancer. Black women are more likely to be diagnosed with a particularly aggressive breast cancer subtype known as inflammatory breast cancer. And there's also an extremely poorly understood higher risk of male breast cancer in the African American community. So all of these characteristics are very strong reasons why we do have to study tumor biology and genetics as we try to understand breast cancer disparities. And this has been the focus of my work over the past couple of decades. Triple negative breast cancers that I mentioned in the previous slide are breast cancers that are negative for 3 specific markers that we always evaluate in a breast cancer biopsy. Those markers are the estrogen receptor, the progesterone receptor, and HER2/neu, which is a growth factor marker. Triple negative breast cancers are negative for all 3 of those markers. And we see triple negative breast cancer much more commonly in Black women compared to white women, regardless of the age at which the woman is diagnosed with breast cancer, and regardless of the stage at which the breast cancer is diagnosed, which is what I'm depicting on these bar graphs. Now, in recent years, we've witnessed an interesting phenomenon where the incidence rates of breast cancer have actually been rising disproportionately in Black women. And now the incidence rates of breast cancer, which previously had been lower in Black women compared to white women, those incidence rates have equalized. So the rising incidence of breast cancer in Black women, coupled with our higher risk for developing these intrinsically aggressive triple negative breast cancer, has resulted in a widening of the mortality gap. And today, death rates from breast cancer are 40% higher in the Black community compared to the white community. And it's important here to make some comment on mammography screening. As some of you in the audience may be aware, there is a lot of controversy regarding the age at which American women are recommended to start screening mammography to look for a small early stage breast cancer. And the United States Preventive Services Task Force currently says that all women should wait until they reach age 50 before they have their mammograms, which is in contrast to the historic recommendation of telling women that they should start at age 40. Well, those of us that are dedicated to breast cancer disparities research are really concerned about that message that women wait until age 50, because Black women, as I mentioned previously, are more likely to get breast cancer at younger ages. And as shown on this bar graphs, in all age categories, Black women are more likely to get these biologically aggressive triple negative breast cancers compared to white women. And so waiting until we reach age 50 is going to result in a widening of the mortality gap. The critics of screening mammography like to point out that these aggressive tumors, triple negative breast cancers, are more difficult to detect on mammogram, which is true, but our group has documented data. This is taken from one of our recent studies looking at the triple negative breast cancer database from our team in Detroit, the Henry Ford Health System, and our team here at Weill Cornell, where we combined all of our triple negative breast cancer patients together, and we definitively showed that mammography screen detected triple negative breast cancer results in a survival advantage for both Black women and white women, but the survival advantage was especially strong in the Black women. So we argue that screening mammography is even more important for the African-American community. Through the Henry Ford Health System, we wanted to evaluate this question of whether there was something intrinsically different about the breast tissue of Black women compared to white women, predisposing us to these aggressive tumors. And so we looked at our benign breast disease cohort. We looked at women that had undergone breast biopsies that were benign, and we wanted to see the types of breast cancers that these women with benign breast tumors subsequently developed. Because in general, women that have benign breast biopsies are at higher risk for getting breast cancer in the future, but they almost always get an estrogen receptor positive breast cancer. In this series, with more than 10 years of follow-up, the Black women had a fourfold higher risk of getting these triple negative breast cancers, even though they started out with a benign breast biopsy that should have predisposed them to a non-triple negative breast cancer. So indeed, there does seem to be something inherently different about the breast tissue of African-American women. Which brings me to a discussion of our international work. We wanted to do a deeper dive look into the breast cancer burden of women on the continent of Africa, so we could understand whether or not there's some genetic hereditary susceptibility for triple negative breast cancer in African-American women. And for most of the 20 years that we've been doing this work, we've been biobanking tissue specimens from the breast cancer patients that we've evaluated in Ghana, which is located on the western sub-Saharan coast of Africa. And we've also been biobanking specimens from patients in Ethiopia, which is located on the east coast of Africa. And this is a very simplified version of one of our most basic findings, which demonstrates that triple negative breast cancers are extremely common in Ghanaian women, accounting for about half of the breast cancers that we see in Ghana, but only about 15% of the breast cancers that we see in Ethiopian women are triple negative. The frequency of triple negative breast cancer in African-American women is intermediate between what we see in Ghanaian women and what we see in white American women. And so this is where we've coined this term of oncologic anthropology. As you guys all remember from your history classes, the transatlantic slave trade of several hundred years ago brought the ancestors of contemporary Western sub-Saharan Africans, including contemporary Ghanaians, across the ocean to serve as slaves in the colonies. And so today, as contemporary African Americans, we have quite a bit of shared ancestry with contemporary Ghanaians. The slave trade from East Africa, on the other hand, was largely brought further eastward to the Mideast and to Asia. And so as African Americans, we don't have quite as much shared ancestry with contemporary East Africans, including contemporary Ethiopians. And so if there is something, as we hypothesize, associated with African ancestry that predisposes us on a hereditary basis for triple-negative breast cancers, it's likely something specifically related to Western sub-Saharan African ancestry. And so several years ago, I was really thrilled to be able to recruit this card-carrying PhD geneticist, Dr. Melissa Davis, to serve as the scientific director for our international program. And for most of Melissa's career, she has been an expert in studying a particular gene called the Duffy gene. And the Duffy gene is very unique and special in being able to study disparities, because there is a particular variant in the Duffy gene called Duffy null, which is specifically associated with Western sub-Saharan African ancestry. Now, unfortunately, most of the genomic studies that have appeared in the cancer literature have very few individuals contributing genetic data from individuals that have African ancestry, only about 2% as shown from this pie diagram. So the genetic markers that are associated with African ancestry tend to be completely overlooked in the bulk of those studies. So by utilizing the biorepository that we've been amassing through our international work over the last nearly 20 years, we have been able to evaluate some of these genetic markers associated with African ancestry. And in particular, Melissa has been doing studies looking at this Duffy null variant in Black women, white women, and African women with breast cancer, as shown here. And what we found in this very busy slide, I won't belabor the data, but what this very busy table is basically showing is that by far and away, the presence of the Duffy null variant was the strongest determinant or predictor associated with having a triple-negative breast cancer compared to having a non-triple-negative breast cancer. Now, these different variants that are associated with one's ancestry, including the Duffy null variant, which is linked to Western sub-Saharan African ancestry, there are a whole host of these different variants out there. And they don't really pop up randomly. They reflect evolutionary selection pressure on our ancestral populations based upon our ancestors having to survive various threats related to environmental exposure, related to climate, altitude, food sources, related to different infectious diseases. But these variants stuck as you pass through several generations, and so we see them today reflected in the genetics of contemporary current generations, regardless of where those current generations reside. And so you guys, I know, are aware of all of these commercially available products where you can purchase the product, spit into a little cup, and send your saliva off to a laboratory where it gets analyzed, and you get a profile of your DNA telling you where your ancestors resided. And a lot of that genetic work is based upon these types of genetic analyses of these variants that reflect evolutionary selection pressure on our ancestors related to where they lived hundreds, sometimes thousands of years ago. So the Duffy null is just one example of such a variant. The Duffy null variant is a variant that was acquired by Western sub-Saharan Africans many thousands of years ago because the Duffy null variant confers some resistance to malaria. And malaria became endemic in Western sub-Saharan Africa many, many thousands of years ago, because a lot of the tropical areas and the lowland watery areas of Western sub-Saharan Africa support the mosquito life cycle. And the mosquito is the bug that transmits the malaria parasite. There are a lot of highland areas in East Africa, and so there's a different story behind malaria in East Africa, and the Duffy null variant is not seen quite as commonly in East Africans. But the Duffy null variant, which became fixed in Western Sub-Saharan Africans because of its ability to confer some resistance to malaria, it came across the Atlantic Ocean with the transatlantic slave trade, and we see it in between 2/3 and 3/4 of current African Americans, not 100% because of genetic admixture that's taken place in the United States among African Americans. Now, the reason why the Duffy null variant confers some resistance to malaria is because if you have the Duffy null variant, you lack the Duffy protein on your red blood cells, and the Duffy protein basically acts as the entryway for the malaria parasites to enter the red blood cell and to cause the disease. But what we are now learning is that when you lack that Duffy protein on the red blood cell, you also lose some of the buffering capacity that the red blood cell provides to certain cancer-associated circulating chemokines. And it's probably the effect of these different blood chemicals, cancer-associated chemokines, on the mammary tissue that influences the inflammatory landscape of the breast tissue, which then impacts on the likelihood of developing a triple-negative breast cancer. And this is the type of work that's ongoing in our international biorepository run by Melissa Davis. So we're seeking to connect the dots between this Duffy null variant and the actual development of a triple-negative breast cancer. And we've been conducting a number of really exciting genetic studies demonstrating that you can actually characterize a whole series of very specific and unique patterns of triple-negative breast cancer when you look specifically at women that have African ancestry here in the United States and women with African ancestry on the continent of Africa. So we've been very excited about this work. And this international work has been extremely rewarding to us because of those research opportunities, but it's also been very gratifying to us because of our opportunity to then invest in the cancer treatment resources of countries that are woefully under-resourced when it comes to cancer care. And the mission statement for our group, the International Center for the Study of Breast Cancer Subtypes, is to reduce the global breast cancer burden through advances in research and delivery of care to diverse populations worldwide. Several years ago, while I was still at the University of Michigan, we were able to invest in a telemedicine conference facility at the Comfort Teaching Hospital, which was our first group of partners located in Kumasi, Ghana. And this was wonderful because it allowed our group at University of Michigan to convene with our partners in Africa so that we could discuss their breast cancer cases in that same multidisciplinary tumor board meeting setup that I described to you that we conduct here in New York, but which we conducted in Michigan and which most cancer programs conduct throughout the United States. We've been able to invest in the pathology program of our partners in Africa to develop different training programs and advanced techniques such as core biopsy technologies. And we've been able to teach our own trainees about what it's like to work in an under-resourced country where you have to be extremely creative and make do with the resources at hand. So it's been an extremely powerful two-way street learning experience where our team spends quite a bit of time in Africa, and we have our African partners spending quite a bit of time in our different programs, previously University of Michigan, currently here at the Weill Cornell program in New York. Now, we always enjoy when we are in the Comfort Teaching Hospital. This is one of my favorite slides. There's actually a little school in the hospital. So a highlight of each of our visits is to spend time interacting with the kids at the school and bringing school supplies and toys over there to them. And we have, as I mentioned before, expanded to involve some research partners in Addis Ababa, Ethiopia, so that we are able to study the breast cancer burden of women in East Africa as well. Now that our program is headquartered here at Weill Cornell in New York, it's extremely exciting to be able to align our international research studies with research studies looking at the Triborough, New York area, which is beautifully diverse, looking at the breast cancer patients of Manhattan, Brooklyn, as well as Queens. And we've established a footprint now not only in multiple sites in Africa, but also in the Caribbean. And we have a very early site that we are establishing in Brazil. And we do a lot of our research in conjunction with the Englander Institute of Precision Medicine here at Weill Cornell. Whenever I talk about disparities, I always include these three survival rates of 60%, 43%, and 20%. And these survival rates don't have anything to do with cancer outcomes. These are the survival rates for the first class, second class, and third class cabin passengers of the Titanic. And I mention these survival rates because even though my own research is very heavily grounded in studying the genetics of African ancestry and its relevance to breast cancer disparities, but we always have to come back to the critical message that outcome is going to be dependent on access to care, number one. And just as the third class cabin passengers of the Titanic did not have equal access to the lifeboats, it remains true today that our communities of color and our socioeconomically disadvantaged populations, including African Americans and Hispanic Latinx, these communities do not have equal access to best cancer care. And this is definitely going to be problem number one that we have to address if we are going to achieve health equity with regard to cancer, including breast cancer. And as stated by the Reverend Dr. Martin Luther King Jr., of all the forms of inequality, injustice in health is the most shocking and inhumane. Now, this hit us extremely powerfully during the COVID pandemic. We're witnessing the disproportionate severity of the COVID pandemic in Blacks as well as Hispanics and other racial ethnic minorities was so much higher compared to the pandemic severity, which was still severe, but it was even more severe in our communities of color compared to white Americans. And in the midst of dealing with COVID, we witnessed the brutal murder of George Floyd and others in the hands of law enforcement. And so this forced our entire country to confront the impact of systemic racism on all aspects of society, including health. So we then started to embrace a concept that was promoted by the philosopher and civil rights activist Angela Davis many decades ago, where Dr. Davis stated that in a racist society, it's not enough to be non-racist, we must be anti-racist. And so in the context of COVID and witnessing the murder of George Floyd, you see nearly all of our educational systems, all of our professional societies, all of our schools establishing formal anti-racism committees. And this name of anti-racism committee, we established one for our Department of Surgery here at Weill Cornell a couple of years ago as well. It's also very powerful, I think, because the acronym of ARC harkens back to another quote from Martin Luther King Jr., where he stated that the arc of the moral universe is long, but it bends towards justice. So I've had the honor of serving as the faculty champion for our Department of Surgery anti-racism community since its inception in the fall of 2020. And I have a wonderful group of trainees that work with me on all of our programs. One of the things that we've mandated is that all of our surgery trainees that have dedicated research time lasting at least 1 year have to complete at least one project that addresses health equity and/or disparities. We support all of our trainees to have a national umbrella of mentors from diverse backgrounds. So we support them to be members of the Society of Black Academic Surgeons, members of the National Medical Association, which is our country's large African American medical association, and it was established when Blacks were completely excluded from being able to be members of the American Medical Association. And we also support our trainees to be members of the Latino Surgical Society. We've implemented a program called the Cultural Complications Curriculum into our monthly morbidity and mortality meetings, so that every month we have a case-based discussion of a whole variety of different scenarios that arise in clinical practice, such as addressing patients that are behaving in a racist fashion, dealing with colleagues that are behaving in a racist fashion. So it's a really powerful way to make sure that issues related to diversity, equity, and inclusion are part of our conversations on a regular basis in the Department of Surgery. And we've also been funded by the American College of Surgeons to conduct a pipeline program where we are able to reach out to high school students, college students, and medical students to encourage them to pursue careers in surgery. And here I'm going to wind up here. I know we're running low on time, but hopefully you guys all received an invitation to participate in a program that we launched through this anti-racism committee, where we are trying to introduce young students from diverse backgrounds to the diverse members of our Department of Surgery faculty in hopes of enticing many of you to pursue careers in surgery in the future. And we're convening one of those webinars this evening. So hopefully you guys will be able to join us tonight. We're accepting registrations online right up until the time that we convene, which is at 6 o'clock this evening. And each of us participating from the faculty will introduce ourselves and talk about our own career in pursuing surgery. We will talk about our subspecialties in surgery. And then we're going to have breakout rooms specifically designated for high school students, for college students, medical students, and we'll have separate breakout rooms where we talk about health and mental wellness as a surgeon. We'll talk about different surgical subspecialties and surgical training. So these meetings, they're actually a lot of fun also. So hopefully I'll see a bunch of you there. And I just want to close by thanking all of the many funding agencies and organizations that have supported our work over the year. But I do have to close by a tribute to my own sister, Deborah Newman. I showed you a slide of her at that baby picture shot of us. My sister passed away several months ago from a particularly virulent form of triple-negative breast cancer. And it makes this work that I've been involved with my whole life that much more meaningful to me. And all of my work is now dedicated to Debbie's memory. And I was also asked to close with a slide providing you with my contact information. Totally happy, and I'd be honored to stay in touch with any of you that have any other questions for me or would like to know more about careers in surgery, hopefully. So thank you very much for your time and attention this morning.
That was an amazing presentation. So if anyone has any questions, please feel free to ask Dr. Newman. I really like how you also tied in your family's background with your work. I feel like that's so much more meaningful as well.
Yeah, I've been so blessed to have an incredible family.
Yeah. So Francisco seems to have a question. You may unmute.
Good afternoon, Dr. Newman. Thank you for the presentation.
Thank you for
So I was really interested, more specifically, in your research with the Dolinol antigen. I was taking notes and everything, but I wasn't a bit I'm not familiar too much with it. And I was wondering if you could possibly explain more between the correlation between the Dolinol and the phenotype and the triple negative breast cancer.
Yeah, so thank you so much for asking that question, Francisco. Unfortunately, in the interest of time, I had to cut out a lot of the slides that go into more about the connection. But the Duffy null protein when it's lacking in the red blood cell, it confers resistance to malaria, as I mentioned, because the Plasmodium parasite that causes malaria enters the red blood cell via that Duffy protein. So when you carry the Duffy null variant, you don't have that protein on your red blood cell. And it blocks the Plasmodium parasites from being able to enter the red blood cell. So because malaria is such a deadly disease, the African genome in Western Sub-Saharan Africa was under tremendous evolutionary selection pressure to acquire a number of variants that would confer some protection. And so you see this Duffy null variant in nearly all contemporary Africans on the Western continent of Africa. Sickle cell is another example of a variant that confers against malaria. But because cell anemia is also a deadly disease, you don't see it to the same frequency as you see the Duffy null. But Duffy null doesn't have as many adult health consequences. So you see it in all Africans today on the Western coast. And other research has definitely documented that when you lack that Duffy protein on your red blood cell, you have a different balance of levels of circulating chemokines. And this is where we think that there's an impact on the breast tissue, because triple negative breast cancer in particular has an interesting correlation with the inflammatory landscape of the breast. And so now we're working on connecting the dots between this Duffy null variant, levels of different chemokines, and the microenvironment of the breast tissue related to some of these inflammatory markers.
So there is the correlation, there is research to support that, and that's what you presented. I get it now.
Yeah, but it's been quite a journey, and it continues. There are still a lot of questions that we need to answer.
I was hoping I can ask one more question as well.
Of course.
In your research in the at University of Michigan, you went to Africa, right?
Yeah.
I was wondering if you would definitely, what were some of your takeaways from that experience, in a different country and working with other doctors and people alike?
Yeah, so number one, this type of work is extremely expensive because the costs of just the travel and everything, it's very, very expensive. But I've been very fortunate that somehow over the past nearly 20 years that we've been doing it, we've somehow been able to not only keep the program afloat, but to allow it to grow. And so we continue to travel to Africa several times a year. At the height, we traveled probably max 4 or 5 times in a single calendar year. Everything came to a grinding halt, obviously, with COVID. And we were actually in Ghana in March of 2020 when the New York, the first epicenter, and we weren't able to travel at all for the rest of 2020 or for 2021. But we did resume travel this past September back in Ghana, and we expect to be in Ethiopia sometime in 2023. So we are back up and running, but it is very expensive work because of the travel. It's expensive because we have to invest in all of these supplies that we utilize when we travel, and we need to, in the spirit of capacity building, we have to leave supplies with our colleagues in Africa because we don't want to be perceived as going there, conducting research, leaving, and not leaving our colleagues with something to help them build on their own resources. So it is costly, but it's absolutely worthwhile. The other big takeaway is that it is still heartbreaking because we do still see very advanced cancers in Africa. But it's also been heartwarming because we've seen improvements, and we're very optimistic that things will improve over the future.
Glad to hear that. Thank you so much.
Thanks so much for that nice comment, Adam. Appreciate it. Well, I also appreciate running over. Appreciate you guys staying, even though we ran overtime. But thanks so much for your attention, and I hope all of you have a wonderful Monday and the rest of your week.
Thank you, Dr. Newman, and thank you for presenting for Hunter College.
Thanks. And I hope you guys join us this evening.
See you soon.
Thank you so much. Thank you so much.